Hi, I'm Mr. Shailendra Singh, consultant pediatric surgeon from Nottingham University Hospital, United Kingdom. I will be talking to you regarding the fluid and electrolyte balance in children. My first topic will be how to write fluids. Whenever somebody comes to you in any form of dehydration, whether it is from the loss of blood or gastrointestinal fluid in the form of diarrhea and vomiting or peritonitis, they have three types of losses. The three main types are, one is called the deficient. In other words, this is the loss which has happened before the patient or the child has come to the hospital under your care. In other words, this is past and we have to take care of that. The second type of loss is ongoing losses. In other words, the losses which are happening right while the child is under your care and we have to take care of that. Because these are sick children, of course, we are not going to feed them and keep them nil by mouth. We have to write fluid for their maintenance, which is called maintenance. So in other words, in any dehydration, blood loss or shock state, there are three types of losses. One is deficient, which is past. One is ongoing losses, which is the current situation. And one is the maintenance fluid, which is the future situation. And we will start by first doing the mathematical calculation, how much fluid to calculate in each of these categories. Then we will talk about what fluid to give in each of these categories. So I'll start first with the category number one, which is deficient. Sorry, the board marker is not working. Deficient. So coming to deficient, you can divide them into three categories, and these are very arbitrary numbers, but they're very useful to start with. One is mild dehydration, other is moderate dehydration, and third is severe dehydration, or which we call shock. So there are three categories: mild, moderate, and severe. So mild, moderate, severe. When you have mild dehydration, that means you have lost 3 to 5% of your body weight. So 3 to 5% of your body weight has been lost. When it is moderate dehydration, that means you have lost 6 to 9% of your body weight. And when it is severe dehydration, or what we call shock, that means you have lost more than 10% of your body weight. So how do you figure out whether somebody is mildly dehydrated, moderately, or severe? One is that there are a lot of charts which have a lot of columns or a lot of rows which talks about various signs, various symptoms. But in life, you do not have time to go through all that. My take on this is very simple. If you have predominantly symptoms and very weak signs, then you are mildly dehydrated. If you have signs and symptoms, that means you are moderately dehydrated. And if you have only signs and no symptoms, in other words, you do not complain, that means you are in shock or you are severely dehydrated. So I would write it here: symptoms predominantly, symptoms and signs in moderate dehydration, and signs only in severe dehydration. So if you are moderately dehydrated, what does that mean? Moderate dehydration means that you have lost 3 to 5% of your body weight. So if I have to take care of that loss which has happened before you arrived in the hospital, I have to give you 30 to 50 ml per kilogram of crystalloid solution. So it's easy to remember: 3 to 5%, 30 ml per kg to 50 ml per kg. If you are moderately dehydrated, your loss is 60 ml per kg to 90 ml per kg. And if you are severe dehydration or shock, or in other words, you have lost 10% of your body weight, you need 100 ml per kg of fluid. So here we have put milliliter per kg, but we haven't put a time frame. This is the fluid which you have to take care before the child goes to theater if you are a surgeon. But if you are a physician, then you can correct this deficit over a period of 24 to 48 hours. And this deficit is added over and above the maintenance fluid, and that is how the fluid is given, and we will talk about that later. So I hope I'm clear on mild, moderate and severe part of the dehydration. So that is the deficit part. The second category is ongoing losses. In other words, the losses which are happening currently as the child is under your treatment and you have to replace them. Now it could be in the form of a diarrhea which is continuing, it could be form of the third spacing from the peritonitis which is continuing, it could be hemorrhage from the spleen which is continuing, or it could be a nasogastric tube which you have inserted and there's a lot of losses which are coming through the nasogastric tube, or they might come with some ileostomy issues and the ileostomy is pouring a lot of losses. So these are ongoing losses. So here the mathematics part is very simple. All you say is mil by mil replacement of the losses which are happening. Now when I say mil by mil, mathematically this is very simple, but these are the patients or these are the children where I get the maximum phone calls because there is no clarity from the residents in their instruction. So what do you mean by mil by mil? It should be written very clearly. You can write, I want the nasogastric aspirate to be replaced mil by mil on 6 hourly basis. In other words, all you are giving an instruction to the nurse is that I would request you to go and empty the nasogastric bag on every 6 hourly basis. Find out what is in the bag. Put that equal volume of fluid over and above the maintenance fluid in the next 6 hours and then keep on repeating the cycle. Now, another thing which I have to remind you is that urine output is not an ongoing loss. This is a very big mistake if you do that. Because if you do that, you would be keep on pumping more and more fluid into me and I'll keep on producing more and more urine. So in other words, urine output is not considered ongoing loss. Nasogastric tube is, abnormal ileostomy losses are, blood losses, third space losses are, and any other losses through any of the drains are the ongoing losses. But you have to tell them how often they need to measure them and then replace them. Because you can say, if you are in an intensive care situation, that replace this losses on every 2 hourly basis because it's a very dynamic situation and that's perfectly fine with you. But if you are dealing with a patient on the floor or in the ward, you can say replace them on every 8 to 12 hourly basis and that is perfectly legitimate. Nobody is going to question your instruction or your order. All they want is a clarity. You can even say that I want you to replace X amount of loss over and above the whatever loss you decide. Let's say I say that 100 ml of nasogastric loss per 8 hour is normal. So anything above 100 ml has to be replaced mil by mil on a 6 hourly basis. That is perfectly fine. All I am trying to tell you is that here there is no calculation, but the problem with this is that there is a communication issue and that needs to be addressed. Now we come to the third category of losses, which is called the maintenance fluid. Now, maintenance fluid is written by a formula which is called 4:2:1 rule. And if you understand this rule, you will never be afraid of writing a maintenance fluid for any child or any person of any age, because this formula is based on the weight. So if we go by the maintenance fluid, the first 10 kilogram of the weight of the child gets 4 ml per kg per hour of crystalloid solution. We'll talk about the fluids into each category. We're just doing the mathematics part, how much to give into the each category. So any weight of a child which falls in the category of 10 to 20 kilograms will get an additional 2 mil per kg per hour of fluid. And anything of the weight which goes above the 20 kilogram category will get additional 1 mil per kg per hour. So if we calculate the maintenance fluid for a 25 kilogram child, as you can see, the first 10 kilogram of the 25 kilogram falls into this category. So that will require 4 into 10, 40 mils an hour of the crystalloid solution. Now, next 10 kilogram of this 25 kilogram falls into the second category, which gets fluid at the rate of 2 ml per kg per hour. So this will get 2 into 10, additional 20 ml per hour. And the next 5 kilogram falls into the category above 20 kilogram, which will get 1 mil per kg per hour. In other words, that 5 kilogram will get 1 into 5 is equal to another 5 ml per hour of fluid. And if you total it out, the child needs 65 ml per hour of fluid. So this is how you calculate the fluid for the children. And if you know this formula, the rule is 4:2:1. You must remember this for your life. Now, if you are dealing with adults, you can calculate the fluid with this, but your maximum limit is that in case of male, usually it is 2.5 liters, and in the case of female, it is 2 liters. You don't give above that unless there are some exceptional circumstances, whether it's because of they are having a fever, or the temperature is very high in the environment, or they are very built is very big. I mean, those are exceptions, but otherwise for the males 2.5 and for the females 2 liters in 24 hours is the maximum. You go with these formulas. So now we have calculated the deficit, we have calculated the ongoing losses, and we have calculated the maintenance. So supposing somebody comes to you in a shock state, you don't have a time to do all these calculations in the emergency situation, because you will look very geek, you don't know what you're dealing with, and you will not inspire confidence. So you have to give some sort of bolus fluid. And what is that bolus amount? That bolus amount is 20 ml per kilogram of crystalloid over 10 minutes. So why is this figure of 20 ml per kg over 10 minutes derived? The reason for that is that the blood volume of a normal child is 80 ml per kg. So 20 ml is 1/4 of the 80 ml per kg figure. So in other words, if you misunderstood my dehydration status, I was mildly dehydrated, but probably you were more in shock than the patient, and you in hurry ordered a fluid bolus of 20 ml per kg. If I am a child with a healthy heart, healthy kidneys, and healthy brain and healthy other organs, which most of the children are, I can handle 1/4 on top of my normal blood volume, which is 80 ml per kg. So in other words, I can handle 20 ml per kg unnecessarily given on top of my blood volume of 80 ml per kg without going into any compromise. So that is why this figure of 20 ml per kg has been derived from the pediatric practice, although this is also used in the adult. So you give a fluid bolus of crystalloid of 20 ml per kg over 10 minutes, then you assess the situation. And then once you have given this fluid, then you minus this fluid from rest of your calculations, which we'll see later on. If you have given a 20 ml per kg bolus and the child or the adolescent has not come out of the shock, then you can repeat the bolus of 20 ml per kg. And if the child still does not come off from the shock, then you are not supposed to give a third bolus of 20 ml per kg. Rather, you should take 2 steps. One is call your seniors because this is a serious situation. 2, ring the blood bank because this child will need a blood transfusion. And thirdly, start preparing your endotracheal tube and your laryngoscope, because this is not going to be a C problem. It is going to become a A and B problem. In other words, you give 2 boluses and then the blood. So you are not allowed to give third bolus of 20 ml per kg unless the blood is not available. I hope I'm very clear. So let us now pause for a minute while I wipe this out. So let us do a calculation. Supposing you have a 25 kilogram child. Let me just dry the boat. And this child comes to you in shock state. So the weight of the child is 25 kilogram. He has come to you in shock or severe dehydration. So we talked about that. The deficit of this child is 100 ml per kg, because this child has lost 10% of the body weight being in shock. So for 25 kilogram, this will be 25 into 100 is equal to 2500 ml. So this is the deficit which you have to correct. As we talked, if you are a surgeon and you are going to take this child to operating theatre, then you have to correct this deficit before the child undergoes a general anesthetic. The reason is that if you don't correct this deficit and the child undergoes a general anesthesia, there is a vasodilatation secondary to anesthesia and the blood pressure will go down and it will be an unsafe situation. So that is why. But if you are a physician and you are dealing with gastroenteritis, then you can correct this deficit over a period of 24 hours. Then second category is ongoing losses. And here the calculation is simple, mil by mil. And the third category here is what is the maintenance fluid. So the maintenance fluid, we talked about that, will be for first 10 kilogram, it will be 4 mils per hour, which is 40 mils per hour, sorry. The next 10 kilogram of this body weight falls into the category which will require 20 mils per hour, and next 5 kilogram will fall into the category which will require 45 mils per hour. Total will be 65 mils per hour of fluid. Now supposing you were to correct the deficit over a period of 24 hours, you will divide this with 24, and just to round it off, this will become roughly 100 mils an hour. So you will add this on top of that. So this child should be getting fluid of 165 ml per hour of crystalloid. So that is how you calculate. And if you have given any fluid boluses, they should be subtracted from this figure of 2500 ml. Is it clear? Now, I must stress that all these formulas are a rough guide as to how to start. They are not written in the stone. It's not that once you have written and calculated that you carry it on for the next 24 hours. No, it is a dynamic situation and you reassess the situation after 4 to 6 hours, and depending upon the urine output, depending upon the central venous pressure, if you have the facility to monitor that, or even the pulmonary artery wedge pressure, if you have facility to monitor that, because the patient is in shock, of course you will have a lot of lines in this child, and then depending upon that you give the fluid. But this is good to remember all these formulas because they will at least tell you what and how much to start to begin with. So I hope I'm very clear on this. So 20 ml per kg of bolus, then you subtract your bolus out of the figure of the deficit, and this is how you calculate the deficit, ongoing losses and maintenance fluid. So we know how to get and how much to give into each category. So in summary, deficit is categorized into mild, moderate and severe dehydration. Mild is 3 to 5% body weight loss. Moderate is 6 to 9% loss of body weight, and severe or shock is 10 or more than 10% loss of the body weight. And if it is severe, it means 100 ml per kg. If it is mild, it is 30 to 50 ml per kg of deficit, and if it's moderate, it's 60 ml to 90 ml per kg of deficit. Ongoing loss is in mil by mil replacement, and maintenance is calculated on 4:2:1 formula, and that will clarify. Now we will talk what fluid to give into each categories. In other words, what fluid to give in deficit, what fluid to give in the maintenance, and what fluid to give in the ongoing losses. So we'll talk about that. So the categories remain the same, the three categories which we talked. So let's talk about the easiest one first, which is the maintenance fluid. Now the maintenance fluid depends upon where in the world you are practicing. But I'll first tell you the United Kingdom's guidelines. As far as the United Kingdom's guidelines are concerned, this fluid is 0.9% saline, which is nothing but normal saline or 1N saline, in 5% dextrose plus potassium chloride added as 10 millimole per 500 ml bag, in other words, or 20 millimoles per liter. So this is the standard maintenance fluid which is recommended by the National Institute of Clinical Excellence, in other words NICE guidelines, and it says that you give 0.9% saline in 5% dextrose with added potassium in the ratio of 20 millimoles per liter, because most of the bags are half a liter, so you will be having 10 millimoles in that 500 ml bag. This is the fluid which is currently being given as per the national guidelines. Now, if you are in United States of America or Australia or other parts of the world where I had the privilege and the honor to work, this fluid is actually 0.45% saline. In other words, half strength saline in 5% dextrose with the KCl in the same ratio. In other words, in United Kingdom, we are giving normal saline in dextrose, whereas in rest of the world, it is half strength saline. So that is the maintenance fluid. And we know how much to give by 4:2:1 formula. Then coming to the ongoing losses. To keep your life simple, ongoing losses are usually covered by 0.5% saline, which is again 1 normal saline, plus KCl, again 20 millimoles per liter. As you can see that in the case of ongoing losses, the fluid does not have dextrose. Otherwise, it is similar to the fluid which is written in the maintenance. So this is usually the fluid which we give for covering your nasogastric losses or covering the ileostomy losses or covering any other losses. The only exception to the rule is that when you are dealing in the children with a pyloric stenosis or in the adults with the gastric outlet obstruction, then you may switch this fluid to 0.45% saline. The reason being that the sodium concentration in the gastric juice is usually 40 to 80 millimoles per liter. So in other words, N/2 saline or 0.45% saline with KCl is adequate for those situations. But otherwise, for all other category of losses which we see in surgical practice, it is 0.9% saline with KCl 20 millimoles per liter. Now we will come to the deficit. In deficit, you have two choices. One is you resuscitate a patient and compensate for their deficit with colloid, or you can use crystalloid. I must remind you that all the formulas which I gave you of how much fluid to calculate in deficit, maintenance and ongoing were for the crystalloids and they were not for the colloids. So the colloid into crystalloid controversy only comes in the category of the deficit. How do you correct? And still it's not settled. So coming to colloids, you know the colloids could be blood, the colloids could be plasma, colloids could be human albumin solution, which could be 4.5%, 5%, or even 20%. And then you have some synthetic colloids like jello fusion, hetastarch, hemaxil, and many others. And then in the crystalloid, you have mainly two categories. One is your normal saline, and second solution which you have in crystalloid is Hartmann's solution, and we'll talk about that. So first is the colloid versus crystalloid choice. It is not only a matter of preference. So let me just go back to the first colloid into crystalloid and why one is superior to other in certain situations and one is superior to other in the other situations. So if you have to understand, go back to the body compartments. So you have the major compartment where the water is stored is the intracellular compartment. Then you have another compartment which is extracellular, but it is divided into two parts. One is intravascular compartment and other is the interstitial space. So you have intracellular fluid and you have these two compartments which are extracellular fluid, and this is divided into two spaces. One is intravascular compartment and the other is interstitial compartment, or which is extracellular and extravascular fluid. Supposing I lost let's say I lost 500 ml of blood from my intravascular compartment from any type of hemorrhage, be it a gunshot wound, be it a ruptured spleen from blunt abdominal trauma, and you want to resuscitate me. If you resuscitate me for 500 ml of blood loss with colloid, you just have to give me 500 ml of colloid, whether you give it in the form of hemaxil, gelofluin, or synthetic colloids, you just have to give me 500 ml. The rationale is that what you give stays into this compartment. But supposing you want to resuscitate me with crystalloid and I have lost 500 ml of blood, you have to give me 2 liters of normal saline to compensate for that 500 ml of blood. And reason for that is that when you give 2 liters of crystalloid, 500 ml stays here in the intravascular compartment and 1500 ml gets into the interstitial space. So in other words, the 2 liter which is given to me in the form of crystalloids, only 1/4 of that stays into the intravascular compartments and 3/4 goes into the interstitial space. In other words, this 2 liters is distributed equally into the extracellular fluid. But if you were stupid enough, which I'm sure you are not, and you want to resuscitate me with 5% dextrose because you don't have the other solutions or you don't know the fluid knowledge, you will have to give me 10 times. In other words, 5 liters of 5% dextrose to compensate for my 500 blood loss, because that 5 liter will get distributed into all the 3 compartments, including the intracellular compartment. So that is why 5% dextrose on its own is never ever used as a resuscitation fluid. So remember that for life, and there is a logic for that. Now, if the colloid was such a good thing that we give it 500 ml for the 500 blood loss and it stays in the vascular compartment, why don't we use colloid? Why is the controversy between colloid and crystalloid? There is some reasons. There is a merits in both fluids. If you give me colloid in a situation, let's say I was in emergency, I had an accident in avalanche over a mountain and I was left unresuscitated for 5 to 6 hours. I was in shock, I was anoxic, I had a metabolic acidosis. So I have what you call leaky capillary syndrome.
Thank you for listening to another podcast brought to you by School of Surgery. Remember, you can follow us on Facebook at School of Surgery, on iTunes, on Podomatic at schoolofsurgery.podomatic.com, and finally by searching School of Surgery on YouTube. Thank you very much, and see you next time.